Therefore, I must admit that this is the first time I'm on a professional basis here. And maybe this is the reason why my secretary forgot to load my stick with one part of this talk. That's mainly the part of acute pancreatitis. But as I'm an academic surgeon, I will try to deliver this lecture on acute pancreatitis, at least on all sides. Now, when we are dealing with surgery for acute pancreatitis, we have, of course, to see the time course of the disease. And the time course of the disease is divided into two phases. The first phase is what I would call the chemical inflammation, which is characterized by multiple organ failure. And then there is the second phase, which is characterized by a secondary bacterial infection, which is mostly caused by a bacterial translocation from the small and large bone. I will show you that, let's say, the formerly fatalistic aspect or attitude towards chronic pancreatitis has changed dramatically. It has become much more aggressive, but at the same time there is a shift of paradigm in the treatment concept of acute pancreatitis. We try to be as conservative as possible. And when we are dealing with what is left for the surgeon in acute pancreatitis and how the surgical management of acute pancreatitis should be, we have mainly to ask three questions. First question is, who should be operated? I think there is no question that the patient in the first phase of acute necrotizing pancreatitis should not be operated. This is, let's say, a phase which is primarily the domain of intensive care therapy, cannot change the course of the patient with multi-organ failure, which is developing very rapidly after onset of symptoms. So the one indication, one proven indication who would benefit from a surgical approach is the patient with infected necrosis. What is very questionable is the patient on long-term intensive care therapy who develop multi-organ failure, which is resistant to intensive care therapy, but where we are not able to prove infection, bacterial infection. Now, there has been in the past considerable debate about the best method of proof of infection should be, and in my opinion, the best proof is probably fine needle aspiration. And under a ultrasonography guided or CT guided fine needle aspiration of the necessary. But of course, when you are applying this method, you have to be very well aware of the time course of the disease. And I think at the time when Weger from Ulm performed these studies, it was still possible to do these studies. Nowadays, the ethical committee will not do these studies, but Weger in late 80s published a landmark study on the timing of the occurrence of bacterial infection in chronic acute pancreatitis. And what he could show clearly is that the peak of the incidence of infection is in the second and third week after onset of symptoms. So it's no sense that you capture a patient with a super or hyperacute necrotizing pancreatitis after 3 or 4 days after onset of symptoms, because you will not be, you are sure that the fine needle aspirate will not contain it. So the one effect and the one patient collective which remains for the surgeon is the patient collective with infected necrosis. Second question we have to answer is when. And this, of course, refers to this timing of the surgical intervention. And the timing of surgical intervention depends very much, let's say, on the demarcation of necrosis. There have been in the past 2 randomized controlled clinical trials, not big trials, but nonetheless randomized trials which have compared early intervention versus late intervention. And both trials have convincingly shown that early intervention always led to devastating complications like intraoperative hemorrhage, and this, of course, had a tremendous impact on mortality of this disease, and both trials showed that a late intervention with a clear-cut intervention, with a clear-cut implantation is obviously the most beneficial for the patient. Third question is, and that's really all what can be talked or what can be told about surgical management of chronic pancreatitis. How should we approach this? And of course, we have our let's say, concept is, of course, to abolish the focus of capillary infection. This means, namely, a necrosectomy, not a formal pancreatic resection. And then you will have 3 concepts which might be possible. You might close the abdomen and do a bilaterally on demand. The patient will deteriorates in the thermal course. You might submit him to a continuous lavage, closed lavage, or you might submit him, what we, for example, do in my institution, stage 11. I think when you do a meta-analysis, and there are 2 meta-analyses comparing these 3 methods, there is no clear-cut advantage for either. So it's just a matter of philosophy. I just want to know what's going on in the belly of the abdomen, in the belly of the patient, and that's the reason why I take him every stage. That's basically what remains for acute pancreatitis for the surgeon. Now let's move on to chronic pancreatitis. And there, as I outlined earlier, in the past there has been a very fatalistic attitude, and this attitude has been mostly attributed to a burning out hypothesis which was proposed by Amann from Zurich. And he said, of course, in Western Europe, the main cause of chronic pancreatitis is alcohol-induced. So if you wait long enough with these patients will eventually become pain-free, and there will be no intervention necessary. No. Further studies, long-term follow-up studies, have shown that this obviously is not true. There is a significant proportion of patients, even after 10, 15 years of duration of the disease, and these are mostly young patients, let's say in the prime of their age, the prime of their life, which are severely incapacitated by pain. And that's the main reason why, let's say, there has been a shift of paradigm, why we have adopted a much more aggressive approach to treatment of chronic pancreatitis. Now, when you look at the morphology of chronic pancreatitis, more than 95% of patients will present with a typical large duct disease. And this large duct disease is usually characterized by a triad of development of an inflammatory mass in the pancreatic head, which we characterize as a pseudo tumor. You, of course, have changes in the ductal pathology, like stone strictures, which can be solitary, which can be dominant, or which can be multiple. And of course, you have parenchymatous pathology, like calcification and fibrosis. 95%, at least in our collective, of chronic pancreatitis patients show ductal and parenchymatous changes of the pancreatic head, and this is the reason why the pancreatic head has been termed as the pacemaker of the disease. When you deal with pancreatic head, in the past, the only surgical treatment which was applicable was, of course, the whip operation. And I mean, in dealing with a principally benign disease, in chronic pancreatitis, and sacrificing principally not affected organs because of the surgical strategy, like maybe taking out the duodenum, taking out the bile duct, is of course over-treatment. And when you consider the, let's say, mortality rates for a Whipple procedure, just 20 or 15 years ago, they were ranging between 25 and 10%, 15%. Of course, the gastroenterologist was very, very reluctant to refer a patient to a surgeon. Also, they thought about other alternatives, and of course, there is a interventional endoscopy, either by stenting or by combination stenting and extracorporeal shockwave lithotripsy, a procedure which is well known for kidney stones. Now, this is a study, a randomized controlled clinical study from Amsterdam, from the Academic Medical Center, where they randomized two fairly small collectives, either to endoscopy or to a surgical drainage operation. And what came out was that surgery clearly had a benefit for the patient in terms of improving quality of life and in terms of alleviation of pain. And this, of course, led to the decision to prematurely stop this study, because the results were so convincing that this interim analysis was convincing enough to stop the study in the middle. What should we do with a patient who is presenting with an inflammatory insular tumor of the head of the pancreas with this duodenal obstruction? Chronic pancreatitis should be submitted to gastroenterostomy. Should we do a bypass by a duodenal jejunostomy, or should we do a Whipple procedure, a duodenum preserving pancreatic resection? Another relatively common problem, rising in approximately 30% of these patients, a patient with a common bile duct stenosis in chronic pancreatitis. And again, the question is, should we do a biliary bypass? Should we do a definitive procedure like a Whipple? Or should we do something in between, a so-called organ-preserving procedure like the duodenum preserving pancreatic resection? The same holds true for this case, a pancreatic cirrhosis with a cystobacterial fistula. Now, when you look at the morphology, and this is a close study of our patient collective, we have now operated more than 750 patients with chronic pancreatitis. Basically, the morphology of chronic pancreatitis can be referred to the appearance and morphology of the pancreatic head, the duct, and the parenchyma, as I've outlined earlier. So it's either a pseudo tumor or a shrinking. And in my opinion, this is the most challenging for the surgeon at least, the most challenging form of pancreatitis, with shrinking fibrous chronic pancreatitis. You might deal with a normal pancreatic duct or an enlarged or a so-called small duct disease, and you might deal with stones or formation of cirrhosis. And when we look at this wide variety of presentation, of clinical presentation of chronic pancreatitis, the ideal procedure should address all these problems. And when you look, the majority of patients have an inflammatory insular tumor of the head, 74%. There is a smaller proportion of patients which have stenosis of the common bile duct, approximately 30%, but the majority of patients have a large duct disease. And of course, you have a majority of patients, 88%, with calcifications of cirrhosis. And when you look with these 1,500 patients which were analyzed, this is an analysis of a combined series from Hamburg surgeries. Here is 750 patients and 750 patients which were treated endoscopically. You will see that the majority has an inflammatory pseudotumor of the head, and the minority has single changes. So, a one-shot therapy is probably the treatment of choice, since no accurate diagnostic tool exists to differentiate causal pathologies, including pain from painless active components. And when you look at the pathophysiology of chronic pancreatitis, it could be either elevated parenchymal pressure, the so-called retroperitoneal compartment syndrome as addressed or postulated by Howard Rieber from Los Angeles. It could be a common bile duct obstruction with, let's say, slight bouts of recurrent cholangitis. It could be an elevated pancreatic duct pressure. It could be pain memory in the brain, because we are intelligent. We try to memorize our pain. It could be a parapancreatic neural infection or the cephalic tubercle. So as I said, the pacemaker of the disease is the pancreatic head, and 95% of those patients show these changes, and basically the pacemaker of the disease will lead to 4 changes. And the most significant change is, of course, the common bile duct stenosis. It's a stricture of the main pancreatic duct. It's a compression of the mesenteric-portal axis, leading to segmental portal hypertension or luteal obstruction. And of course, the symptoms which I have outlined now are basically the symptoms of pancreatic ductal adenocarcinoma of the pancreatic head. And this was the reason why most surgeons in this setting favored a Whipple or virus-preserving pancreatic lumpectomy. Now we have a slightly different philosophy. We try to put in morphologically adapted therapy in chronic pancreatitis, and our rationale is first a resection of the inflamed pancreatic head. With this duodenum-preserving coring out of the pancreatic head, you can decompress the common bile duct, so you relieve the problem of common bile duct obstruction. You can relieve the decompression. You can achieve the decompression of the duodenum, so you can relieve duodenal obstruction. In some anatomical variations of this procedure, you can relieve segmental portal hypertension by decompression of the mesenteric portal axis. And of course, you are dealing with the pancreatic duct by a combination of drainage and resection. Now, important questions which are so far unknown in chronic pancreatitis is, of course, the timing of surgery. There is one tiny randomized trial coming from Galveston, Texas, where Bill Nealon has compared late surgical versus early surgical intervention in patients with so-called mild chronic pancreatitis, and he could clearly show that in this small randomized trial, early intervention had a significant benefit on the natural course of the patients. I think so far standard surgical procedure has not been defined, and I think the issue which has been resolved is endoscopy an alternative to duct strictures or stones. I think when you are dealing with a dominant stricture, this is the ideal case for endoscopy. But when you're dealing with a complex case, like what we have seen in our practice, then this is no place for endoscopy. When you look at the evolution of modern surgery for chronic pancreatitis, the one who deserves, let's say, to introduce for the first time an organ-preserving principle was Hans Beger. This time he was a senior registrar in Berlin when he devised this operation, and as you can see, the steps of the operation are, at least at the beginning, essentially the same as with the Whipple. You do an extensive coagulation of the Whipple, of the duodenum and the pancreatic head, and then you transect the pancreas above the portal vein. Of course, for every surgeon, who is, let's say, familiar with this disease, everybody knows that especially this step can be pain in the neck, as I might say. It's a very demanding step, especially in chronic pancreatitis. A patient with pancreatic cancer is much easier to operate than a patient with chronic pancreatitis. And then the difference starts. He refrains from resecting the whole pancreatic head and uncinate process, cores out the pancreatic head, a subtotal pancreatic head resection, decompressing the intrapancreatic portion of the common bile duct and the duodenum. And of course, by transection, you achieve the decompression of the portal vein. The reconstruction is relatively complex. It consists of a double pancreatojejunostomy. The one anastomosis is done to the pancreatic remnant of the body, and the second anastomosis with the same loop is done to the resection cavity of the pancreatic head. This operation introduced for the first time an organ-preserving principle, but it has not gained very much, let's say, distribution in the world, probably due to the fact that this operation is very difficult. Now, Charlie Fry came from a different approach. He said to himself, why can't I do an extended drainage procedure? So he came from a Partington-Rochelle procedure, and he did tiny, limited local excision of the pancreatic head. He claimed that he could decompress the common bile duct, although when you look at his first series of patients which he published, he had a tremendous proportion of patients which needed radioenteric anastomosis. And then this operation, of course, refrains from transection of the pancreas. It's much easier to perform, and you know, this anastomosis from the Partington-Rochelle procedure is the lateral pancreatitis. And in small duct disease, we have devised an operation based on, let's say, the good results, which we have seen this duodenum preserving principle. You know that small duct disease usually is the domain of nature. Resectional procedures like 95% subtotal pancreatectomy. And in order to preserve the organ, we tried with this operation to create a new pancreatic duct by cutting a choke over the whole aspect of the ventral aspect of the pancreatic gland, and then do a pancreatico-jejunal anastomosis. The rationale was that by creating this choke, this new pancreatic duct, we would achieve the drainage of the second and third order pancreatic duct branches. So, of course, the main parameters when we compare these procedures are pain relief and quality of life. And I think there are various trials showing that duodenum preserving procedures have been shown to be highly effective, as you can see in these trials. Now, there are two randomized controlled clinical trials comparing surgery versus endoscopy. Both trials showed that surgery was superior to endoscopy. There was one randomized trial comparing extracorporeal shockwave lithotripsy versus a combination of both procedures. And there are 8 randomized controlled clinical trials comparing various surgical procedures. And I will show briefly the results. So this is the first trial where pyrrhus-preserving pancreatitis was compared with a modified Fry procedure, what we call the Henbrook procedure, an extensive coring out of the pancreatic head. You see a fairly large trial, 30 versus 31 patients. And as you can see, the pain score quality of life was measured prospectively in these patients. Quality of life after 24 months was the score was 62, and as you can see after Fry procedure, it was 86. So it was better at this time. In hospital morbidity, of course, for the PPPD was higher. than with the Frey procedure, so at least there was to be a short-term benefit of the Frey procedure. The same was true for the pyrus-preserving whipple versus the Beger procedure, a trial which was published by Markus Richter. And when you look at the long-term results of those trials, you will see that in comparison of the Beger versus the easier Frey procedure, there is essentially no difference between both. This is a study of a randomized trial which we did in Hamburg, and this is the 8-year follow-up, which was published in Annals of Surgery. And as you can see, the numbers are essentially the same. The same holds true for pain-freeness or alleviation of pain, and the same holds true for quality of life after immediate pain. So, in conclusion, I think that overall many chronic pancreatitis patients benefit from the existing organ-sparing procedures. In our opinion, the morphologically adapted surgical approach is mandatory in those patients combining resection and drainage. Of course, this needs a careful assessment of the chronic pancreatitis patients because this is a custom-tailored or customized surgery for each individual patient. And I think the place of endoscopy is just for patients with a solitary dominant stricture of pancreatitis. Thank you very much for your